Hello and welcome to the St. Michael Medical Center Weight Loss Surgery Seminar. This presentation will serve as a basic introduction to the weight loss surgery program. As you make your way through the presentation, I encourage you to jot down any questions you may have, and we would be happy to address them for you at your next appointment or through our contacts listed at the end of this presentation. First, we would like to introduce you to our surgeons. My name is Kevin Clive, and I am a general and bariatric surgeon at St. Michael Medical Center located in Silverdale, Washington. I received my medical degree from University of Cincinnati in 2007 and completed my general surgery training at San Antonio Military Medical Center in 2013. I am currently a fellow of the American College of Surgeons, a diplomat of the American Board of Obesity Medicine, and a member of the American Society of Metabolic and Bariatric Surgeons. I spent 11 years in the Army caring for our soldiers and their families, and transitioned to my current practice here at St. Michael in 2018. I am very pleased to introduce Dr. Angel Reyes, a bariatric surgeon joining us at St. Michael Medical Center. He completed his residency in Augusta, Georgia in 2007 and a fellowship in minimally invasive surgery and bariatric surgery in 2013 at Virginia Commonwealth University in Richmond, Virginia. He is recently retired from the Army after 20 years of service caring for our soldiers and their families. He belongs to numerous surgical societies and recently received his board certification in obesity medicine to better serve our bariatric surgery patients. The purpose of this seminar is to provide you with a basic knowledge of our multidisciplinary weight loss surgery program. Our mission is to provide a comprehensive approach to address your healthcare needs. This is achieved through a foundation of nutrition education, physical therapy support, and behavioral modification through our behavioral health resources. Patient safety remains the top priority throughout our program and is the driving force behind the preoperative processes, to include diagnostic studies and procedures. Ultimately, we aim to ensure that we give our patients the best chance at long-term success while helping them achieve their health goals. We believe that this process will allow our patients to lead happy and healthy lives without a need for further interventions. In order to understand the qualifications for weight loss surgery, we first need to define the criteria. Body mass index is a crude measurement of weight to height ratio and serves as the basis for who meets criteria for weight loss surgery according to the National Institute of Health, as well as insurance providers. BMI does not take into consideration an individual's age, sex, race, or muscle mass. It is not a direct measure of body fat. However, increased BMI is associated with increased risk for other chronic health conditions. The BMI is calculated by dividing the weight in kilograms by the height in meters squared. The same calculation using weight in pounds and height in inches is listed here as well. The World Health Organization defines class of obesity based on BMI, which are demonstrated here in bold. These will serve as a reference for those who meet criteria for weight loss surgery. Who typically qualifies for weight loss surgery? Patients with a BMI of greater than or equal to 40 and those with a BMI of greater than or equal to 35 with coexisting medical conditions such as diabetes, hypertension, obstructive sleep apnea, fatty liver disease, joint disease, high cholesterol, reflux disease, heart disease, and others. Most insurance providers include requirements for documenting failed attempts at weight loss through diet and exercise. It is critical that women of childbearing age avoid pregnancy for up to 2 years after surgery due to the potential risks to the fetus during a period of caloric and nutrient deficiencies. Finally, it is mandatory to abstain from all tobacco and nicotine products to avoid postoperative complications and to promote a healthy lifestyle. The multidisciplinary pathway to weight loss surgery starts with completing the educational seminar here. The order of the steps listed here may vary slightly depending on the patient and their insurance carrier. Following the seminar, we will usually see patients in the office to review their medical history, perform a physical exam, discuss surgical options, review insurance requirements, and lay out their individualized pathway based on the overall evaluation. Patients leave that visit with a checklist of appointments and tests to be performed prior to surgery. Once the program and insurance requirements have been met, patients will complete pre-surgery studies which are based on their medical history. These will be discussed further in a later slide. After obtaining these studies, the patient will meet with us to review results, discuss treatment goals, and determine which procedure is most appropriate. Surgery will be scheduled at that visit. After surgery and a short hospital stay, patients will have scheduled follow-up with our team. Additional follow-up with nutritionists, physical therapists, and obesity medicine specialists are available as needed. Our goal at St. Michael Medical Center is to provide comprehensive care to all patients seeking weight loss surgery services. However, there may be certain circumstances where patients may benefit from receiving their care at another facility where additional resources are available. These patients may include those with organ failure, on a transplant list, have a history of prior transplant, or have significant cardiac or respiratory impairment. These patients may be referred to a tertiary care center to ensure best possible outcomes. Let's further discuss the preoperative evaluation. As I stated, our patients will undergo nutrition education in preparation for surgery, have a behavioral health evaluation, and may receive evaluation by physical therapy to assess physical limitations and provide options for a healthy, active lifestyle both before and after surgery. Patients may also meet with our obesity medicine specialists for assistance with medical evaluation and optimization in the perioperative period. Many patients may require evaluation by our sleep medicine specialist for sleep apnea treatment. If you are currently being treated for this and are actively followed by a specialist, this will not be necessary. Patients that experience pain in the right upper abdomen after eating or at regular intervals will be assessed for gallstones using an abdominal ultrasound. This problem can be addressed at the time of surgery if necessary. All patients will be evaluated with a swallow study to look for a hiatal hernia. This is performed by drinking a contrast agent that shows up on X-ray and can demonstrate a hiatal hernia that may have otherwise been missed on endoscopy or at the time of surgery. Having this information allows us to plan surgery appropriately. Finally, upper endoscopy is performed by placing a flexible tube with a camera through the mouth, down through the esophagus and stomach to the level of the first part of the small intestine. This is done under sedation, usually lasts about 5 minutes, and allows for detection of changes from reflux disease or less common diseases that may change the type of surgery we would recommend. The typical surgical procedures for weight loss are listed here, and we will discuss them further in the following slides. Our preferred surgical approach is utilizing the robotic platform, which is similar to laparoscopy and uses 4 to 5 small incisions with long instruments and a camera. This allows for less pain and a shorter recovery. It is unusual to have to perform open procedures through large incisions, but the possibility for this is always discussed prior to surgery. The first procedure we will discuss is the sleeve gastrectomy. This is currently the most common procedure performed for weight loss. The procedure is restrictive in nature, meaning that it limits the volume of food that can be consumed at one time. This is accomplished by using a surgical stapling device and removing the outer portion of the stomach. This is sometimes used as the first stage of a 2-stage procedure for patients with severe obesity. Now let's discuss the risks and benefits of the sleeve gastrectomy. Some of the benefits of this approach are the stomach continues to function normally, but just has a lower capacity with an early sensation of fullness. Patients can expect approximately 65% excess body weight loss in the first 12 to 18 months after surgery. This may vary from patient to patient. So, if a patient has an excess body weight of 100 pounds, they can expect to lose about 65 pounds of that excess weight on average. In addition, we see resolution of other disease processes at the rates listed here. Finally, the procedure requires no other changes to the intestinal anatomy, and therefore does not have the same associated risks that we see with other procedures. The downside of this surgery include that there is a less than 1% risk of leakage of stomach contents from the staple line. Certain measures are taken to minimize this risk and to evaluate for this at the time of surgery. In rare circumstances, the sleeve procedure may cause or worsen reflux disease. This is the reason we evaluate for evidence of reflux changes on endoscopy prior to surgery and may consider another procedure if these findings are present. Finally, there are very rare incidents of blood clots developing in the legs, lungs, or blood supply to the bowel and liver. This is one reason why we insist on early ambulation using leg compression devices and provide blood thinning medications both before and after surgery. The next procedure we will discuss is the gastric bypass. This has been considered the gold standard procedure for weight loss because of its effectiveness and durability. The procedure involves creating a small gastric pouch and connecting a limb of small intestine to this pouch. This is called the roux limb. This limb is then connected to the small bowel downstream to allow for communication of the food channel with the digestive enzymes, where nutrition may then start to be absorbed. This manipulation of the small bowel creates changes in the anatomy that allows for risk we will discuss on the next slide. Because of the small gastric pouch and the bypassed area of small intestine, this procedure has a restrictive and diversion component, meaning it limits the amount of food consumed at one time and the way that nutrition is absorbed. The main benefits of this procedure are that it allows for sustained weight loss as demonstrated in long-term studies following patients for 5 years or more. Patients, on average, will lose approximately 75% of excess body weight in the first 12 to 18 months after surgery. You can see the resolution rates of other medical conditions listed here. The bypass procedure is also a very effective surgery for managing patients with reflux disease and insulin-dependent diabetes. Some of the potential risks associated with the bypass include the same risk for leakage from one of the staple lines as discussed with the sleeve procedure. Patients may also develop ulcers at the connection between the gastric pouch and the small bowel, known as a marginal ulcer. This is more commonly seen in patients that use chronic NSAIDs like ibuprofen and chronic tobacco users. This is one of the many reasons we insist upon tobacco cessation. Sometimes patients may develop what is called an internal hernia, which occurs when the bowel gets caught up in or under the spaces that are created when we manipulate and rearrange the anatomy. Patients may describe an acute onset of abdominal pain that is often associated with symptoms of a blockage. Bariatric surgeons remain vigilant with making this diagnosis and may need to return to the operating room to rule this problem out or to correct this problem. Dumping syndrome occurs due to the rapid emptying of food from the small gastric pouch into the intestine. This often occurs when patients consume a high sugar load, often in a liquid or easily absorbed form, and this leads to symptoms of abdominal discomfort, nausea, diarrhea, sweating, flushing, and a racing heart. This is usually managed with dietary modifications. Finally, as many as 50% of patients may experience chronic nutrient or mineral deficiencies, such as iron deficiency. For this reason, we recommend lifelong supplementation with a multivitamin with iron and additional supplements as needed. We monitor for this throughout patient follow-up. The duodenal switch is the least commonly performed of the procedures we will discuss and combines the sleeve procedure with a long bypass component. This is usually reserved for those patients with superobesity and has been shown to provide the most weight loss, but has also been associated with the highest complication rates. The benefits of this procedure include it has been shown to provide the most optimal glucose control for diabetics in terms of correcting high blood sugars and avoiding excessively low blood sugars. Duodenal switch patients will lose approximately 80% of excess body weight within 12 to 18 months after surgery. Also, this procedure can be performed as a second procedure for patients that have had prior sleeve gastrectomy to facilitate additional weight loss and correction of medical issues. Unfortunately, this procedure has been associated with excessive weight loss and malnutrition, requiring modification of the procedure or even reversal of the surgery. This procedure has the same risks of leak we discussed with the sleeve and bypass procedures. Finally, some patients develop life-limiting diarrhea due to the lack of normal absorption of fats in the diet. The adjustable gastric band is a device placed around the upper stomach with a connecting port located under the skin, allowing for adjustments to the amount of food that can be consumed at one time. While we don't place adjustable gastric bands, we often will manage them if they have been placed previously by filling or removing fluid from the band, depending on the patient's symptoms and weight loss goals. It is not unusual to have to remove these devices or to convert to another weight loss procedure. Our reasons for not placing them include the low success rates for sustained weight loss and the long-term risks associated with them, to include band slippage, progressive reflux disease, and the potential for the band to erode through the stomach. Revision surgery may be required for those patients with complications related to prior procedures or those patients with weight regain, and may include patients who have had prior bands, sleeves, bypasses, vertical banded gastroplasties, and other rare procedures. These procedures are notable for their higher perioperative risk and may need to be performed in stages. The typical hospital stay after surgery is 1 to 2 days. The patient and healthcare team have a clear set of expectations during the hospital stay, as well as discharge goals. These include mandatory ambulation within 4 hours after surgery to minimize risk for development of blood clots. We want to make sure patients are well hydrated and can safely consume more than 1.5 liters of clear liquids within a day. Dehydration is a common issue after surgery and can cause unnecessary returns to the hospital if patients are not prepared prior to discharge. Finally, we want to ensure our patients' pain and nausea are controlled on the regimen made available in the hospital, which will be made available to them after they are discharged to home. The typical post-surgery follow-up is listed here. Dietary tolerance and advancement will be assessed at the first few follow-up appointments, and nutrition labs will be reviewed at subsequent visits. Weight loss surgery patients benefit from annual follow-up with their surgeon indefinitely, which allows for careful monitoring of nutrition status and management of any recurring issues. I want to thank you for your time and congratulate you for taking this first step on your journey toward health. If you have any questions for us, please do not hesitate to contact us at the number listed here or reach out to us via MyChart. Again, thank you and best wishes.